everybody. Welcome back to PCC's UC 2020. Today, we've got a great session. There's Dr. Jeanne Marconi will lead us through her content on improving asthma management for quality and your bottom line. So this is one of those awesome clinical and practice management sessions. You don't want to miss this one. Turn things over to Dr. Marconi.
So I would first like to thank PCC and especially Jeanne for helping me, especially through the technical piece of this, and allowing me to share how you might improve asthma and its management and workflows in your practice, not only to improve quality, but also to maybe improve some efficiency, added value for your patients, and then realize that your bottom line will also improve. Since we have a mixed audience, clinical and admin, I'm going to review some basics about asthma, but not really go into detail about medication management and the like, but more about how you can maybe look at asthma differently in your practice and engage a team to help maybe change how you do it. So just a few. My slide is not advancing, Jeanne.
If you click right on the center of your slide and then start using those arrow keys, that should do it.
All right, there we go. So what I wanted to give you was a little bit of statistics to kind of give you a frame of reference of where asthma is today in our country. So almost 10% of children have asthma or asthma-like symptoms, which translates into about 7 million children. So clearly, we as pediatricians have a huge job to do to address this disease, and especially as the children get older, and this disease also goes into young adulthood, it has significant consequences on not only the patient, but on our systems in general. Those 10% of children reflect 10 million lost school days for their asthma. And this is due to either their asthma treatment, management, exacerbation, and just their well care related to asthma. As you know, asthmatics, diabetics, miss days of school to come and visit with the doctor. There are $726 million of lost revenue because parents need to miss work to take care of their children or young adults with asthma. So it has a significant economic impact on our society. At least 48% of children under the age of 18 will visit the ER at least once for some asthma-related illness. So here is where we can look to maybe make improvements that we keep children in check so as not to have them exacerbate to such a level that they need to use the emergency room. Which we know doesn't always provide the best treatment for kids. Additionally, escalating obesity rates is a newer identified risk for both cause and exacerbation in asthma. And we saw, I think it was last week, the AAP put out something that they expect another 2.5% increase in obesity just related to COVID for the lack of physical activity and probably more scheduled eating during COVID. Asthma medical costs over the ages from infancy through adulthood is in the billions. We really need to find better ways to provide prevention or maintain therapeutic treatment as to not escalate the cost as much as we possibly can. This is definitely a population management disease, and we could all be probably doing a better job in managing it, and we are surely going to be expected to do that as value-based care and new models of healthcare become apparent. So we have, as pediatricians and pediatric healthcare providers and pediatric offices, a great opportunity to improve early recognition, and that's a key word, early recognition, in the treatment and diagnosis and treatment and therapies for asthma. through being aware at every visit to look for some of the signs and symptoms, to make sure that treatment reviews are done in a consistent way and that follow-ups are maintained according to a schedule and not haphazard. And one of the most important things for asthma as we know it is the education and prevention. So working with parents, teachers, caregivers, grandparents, and the patients themselves in finding better ways to manage their asthma. So 2 resources I highly recommend that your practice at least take a look at is the National Asthma Education and Prevention Program, and then all of the materials put out by the National Heart, Lung, and Blood Institute, the NHLBI. The NHLBI is where all the step management guidelines come from, and I'm not going to get into them in too much detail, but we will sort of go over how they can be used in your practice to better manage your patients. So we all, and we meaning caregivers in pediatrics, so that includes the person at the front desk, your admin team, your nurses, your asthma educator if you have one, your providers, schools, parents, coaches, actually all play a very important role in the care and management of children and young adults as identified as having asthma or its related conditions. And we have to remember, asthma just means, difficulty breathing or cough. It's not like diabetes where you have like one factor. Asthma has many factors, and we'll talk about those in a little bit, since it's more like having a stomach ache. So there are so many things that can cause or exacerbate asthma that's why it's important to think about them at almost every visit when these kids come in. Asthma can be, we can limit some of the sort of side effects or worsening of asthma by controlling exacerbations and status asthmaticus. So improving the care or prevention before we get to those points by limiting the number of ER visits and by using as little medication as clinically possible, or all we efforts. So, again, schools, parents, the patients themselves, really, really working with them on how to use their controllers, how to use their emergency medication, and try to get out of the habit or and I'm not saying all of us, but some people just keep refilling their medications, which doesn't really help them very much. The classification of the asthma is really critical in using some of the asthma control tools we're going to talk about, so that we can effectively manage them and make sure that we're meeting the quality metrics that we're expected to, or some new ones that we might want to take on in our practice to improve our pay for performance or work on some quality initiative projects. And asthma is a great one for that because you can take one little piece and really work on it, especially for those of you who need to do your MOC. So we have to realize that asthma visits are unique and that they almost, we can say they come in all different shapes and sizes. So, someone coming in with a cough might not be asthma. We call it asthma, and maybe it's reflux, or they come in with reflux and it's asthma, or they come in with fatigue and it's asthma, or they come in like, I can't play sports because I'm too tired. Well, it's not they're too tired. It's that they have asthma that's been unrecognized or undertreated. Infants are an increasingly underdiagnosed group, probably the most underdiagnosed group. And when you start reading some of the literature, especially babies who have bronchiolitis or wheezing at a very early age, like the 6-weeker or the 2-month-old, those infants need to be followed in a very different way because they are at such a high risk of asthma that probably some of those will continue till they're 3 or 4 and then kind of resolve on their own, or they will continue to get worse. But they are a target age group that we could really make a difference in treating as soon as we possibly can, especially those kids that keep coming back for cough, cough, cough. And they cough at night, and, we're not really recognizing that really that's asthma. It's not just they have bronchiolitis and they have this ongoing cough. They have reactive airways. During adolescence, we see a lot that asthma improves. And it may be due to the hormonal, the growth hormones and things like that are thought to maybe settle it down because they have some anti-inflammatory properties, but only to become return in young adulthood, like in their 20s, when, we might or might not be taking care of them, and they might or, usually do not seek another provider during their 20s, and they're going through those years having restrictive airways only to really worsen in their 30s and 40s. We have recognized that looking at other comorbidities, so many of our asthma patients have more than one diagnosis of asthma, so there could be considered a complex patient. So as you're developing your chronic care management or chronic care manager, looking at asthma as one of these prompts is really important, especially if they have obesity, hypercholesterolemia, hypertension, they lack physical exercise and endurance, they're emotional. Stress is a known contributor to asthma. So making sure when you're working up your asthmatic, you're looking at some of the PED symptom checklists to see what else might be going on, or a trigger that may not be physical related. Environmental exposure, so where they live, what they're exposed to at home, whether it's, insects, pests, or, poor air quality, mold, things like that. So, as we just talked about a little bit before, asthma is really like a wastebasket. It is all over the place. And despite better medications, we still continue to see an increased risk over the past 20 years, which is, of course, concerning. So I'm going to get into, I know this is very basic, but I know that there may be some admin people listening to sort of figure out how to work on an asthma management group in their practice. So we'll just take a couple of slides to kind of go through what some of the things that people might be calling the office for, or that you can associate with your asthma patients. So wheezing, coughing, nighttime cough especially, I can't say enough about that. Cough variant asthma is probably very, very underdiagnosed. And these are kids who come in and the parents say he's been coughing for months. And sometimes just, using an inhaler for a short period of time at bedtime, resolves the cough. And I think many of us forget about this type of asthma. Coughing with, you'll hear this a lot in, your teenagers who come in and track. I cough all the time when I start running, or basketball, or some, really exercise that goes from 0 to 60 in a very short period of time. You'll hear from kids that they have trouble breathing, or it hurts to breathe, or they can't catch their breath. Shortness of breath, tightness in the chest. Reflux symptoms often mimic cough, and cough also mimics reflux. So we have to remember to always keep that in our diagnosis. And fatigue. So some of the triggers, we've already talked about some of them. So the common ones are respiratory infections that then lead to asthma. Kids who have allergies often go hand in hand with asthma. Parents who smoke have children with increased risk and, therefore ongoing asthma. The air temperature we talked about, mold, humidity, toxins such as perfumes, paint, hairspray, pollutants, reflux we talked about, especially obstructive sleep apnea, and especially in your kids with asthma and obesity, this is a very common finding and complaint when you really ask them the questions. A higher incidence for asthma if the mother is obese during pregnancy. Inflammation by, recurrent sinusitis, recurrent rhinitis, are also contributors. Stress, we talked about, emotions, exposure to drugs, especially in utero, exercise, and atopic dermatitis, which sort of goes along with your allergy kids. So when we think about asthma, just some of the epidemiology, just for a quick review, Black and Hispanics are greater than whites. Boys are 3 times greater than girls before puberty and then becomes equal. 20% of infants have wheezing with a URI, and 60% of them will go on to have asthma. So just like we talked about before with the bronchiolitic kids, 60% of them are going to have asthma. So they need to be flagged and monitored very closely, especially if you have a bigger group and they're seeing different providers all the time. Sometimes it gets lost to really sit down and look at the history. So I encourage you with these little ones who seem to come in a lot to really take an extra look. Wheezing that starts above age 6 is typically allergy related, just as an FYI reminder. Asthma as a child, you're 12 times more likely to have asthma at 50. So there's a significant lifelong disease associated with these kids having asthma, and the more episodes they have, then the more disease risk they will have when they get older. And we talked about already morbidity and mortality. Kids still die of asthma attacks, believe it or not. And these continue to increase despite all of our best efforts with controllers and spacers and things like that. So we need to really be doing more. So we have, there's a classification of symptoms of asthma that really need to be put in your charts as under the problem list or their care plan. And all asthmatics should really have a care plan. PCC has a great care plan in their system that it doesn't take very long to fill it out. And it really helps management, especially if different people are seeing your patients, like we talked about before. So there's seasonal, perennial, or both. There's continuous or intermittent. There's day or nighttime, and there's onset and duration. So with the above, and this is really getting into the details for the clinicians, and I'm not going to spend a lot of time on it, but the diagnoses we look for are intermittent, mild persistent, moderate persistent, severe persistent, and unspecified. And it's important to keep those updated in the chart, as well as updating the medications, whether you're going up on meds or down on meds in the medication history. So if your MAs or nurses are doing sort of the check-in, it's very important to document how these kids are doing on their medicine and which ones they're actually taking. Because just because you look in the pharmacy section doesn't mean they're actually taking the medication, or they may have gone to an ER somewhere and somebody changed it, and we rarely find those things out. So once the classification has been determined, you have to do an added classification for the visit. So whether it's uncomplicated, with exacerbation, or status asthmaticus, which means, they're pretty severe and you're either going to do intensive treatment in your office or send them to the emergency room. And a lot of these classifications are really, really, really important if you're doing QI or getting paid for performance. So the more your kids go to the ER, the more they come into the office and they're more, persistent or acute, they're going to be looking at your management and seeing where you can do better. So we're not going to go into the specific therapeutics, as I said, but for the NHLBI, we want to remember that there's different treatments and management depending upon the ages of the kids. So 0 to 4 is one group, 5 to 11, and then greater to 12 is very similar to an adult. So I wanted to talk a little bit about some of the evaluation tools and make sure that you can consider having some of these in your office or making sure some of the patients do. And just as a side, I interrupt this session to mention that because of COVID, we're not really doing a lot of these blow tests in the office right now. But there have been recommendations to go back to a peak flow meter, which kind of comes in waves. It comes in vogue, out of vogue, but at least now, since we can't do PFTs right now, it's a good tool for a patient to have at home to monitor how they're doing. So usually this is for kids age 5 and up, and you look at what the normals are by the height of the patient. So there's a grid. We usually take an average of 3, and these must be done standing up. A lot of people don't realize you're supposed to do these standing up to improve lung volume. It shouldn't be done sitting on the patient exam table, which I often find, even in my own practice, the ancillary staff trying to do a peak flow with them sitting down. You really won't get an accurate number. The CPT code for that, if you do it in your office, is listed there at 94150. Most insurances pay a few dollars, and to me, a few dollars is more than no dollars. And if you get $0, I would still code it because it's something that you did. One of the better tools that we've had in the last few years is the asthma control test, which is one of the health risk assessments. It's a self-review. There's one for parents fill out for children, and there's one that older kids and young adults can fill out themselves. The CPT code for that is 96160. And really, that should be done not only at their asthma visits, but when they come in sick. So if they're coming in for a cough or like runny nose, or they're feeling winded, it's not a bad idea to give them their asthma control test, because it tells you about their symptoms over the last 2 to 4 weeks, not just what's happening today. And it also prompts you to take a look at their medications, and are they really doing their medications? As many of us know, in any chronic disease, compliance is a huge factor for these kids. They never take them on time, they skip days, and as you know, some of the controllers, just don't work that way. So another place where you can provide some education to your patients, and you're probably asking these questions anyway, so you might as well get paid for it. So 96160 is for ACT. Spirometry, as we talked about, is the gold standard. It's on hold now. You can do them with and without bronchodilation. This code is without. So you may be evaluating a patient and their spirometry is low, so you may want to bronchodilate them and give them an albuterol and see if it improves, and compare their loops. So there's 2 different codes for that. Nitrous oxide is something is not widely used yet, but I think I know 2 pediatric practices that are actually doing it. How regularly, I'm not really sure, but the code for that one is 95012. Supposedly gives you a better idea of lung volume, because it doesn't require as much effort as you need for PFTs. So if you're trying to see if a patient has asthma and they really aren't classic symptoms, and you're trying to tweak things out, you can also do the methylcholine challenge test. I don't know too many pediatricians that do it in their office, but it's not that hard to do. And then this one I'm going to spend a little bit of time on. This is a really good test to consider. But you'll need a treadmill, and you can use a treadmill for a lot of things. You can do it for exercise endurance in your obese kids to see what they're going to be able to do and where they can reach their max heart rate at. But this comes in very handy for kids that say that, when they go outside and run, they feel tight, or they wheeze, or they cough, because we never know if it's, breathing dysfunction, or is it endurance, or is it really asthma? So, you have them come in their sneakers, you have the treadmill, you hook them up to a pulse ox, and we get them to maximum heart rate of 60% expected. You do a spirometry at 5, 10, 15, 20 minutes. And if you see that it is decreased, then you can give a bronchodilator and see the results. And, it's not that hard to do, and it pays very well. And not only that, you're actually confirming that they have EIB versus guessing, oh, this is exercise asthma, and just giving them an inhaler, where otherwise you can, if they need to go to ENT for dysfunctional breathing, vocal cord dysfunction, or it's just an endurance problem, you get to tweak it out a little bit more. Pulse ox, again, doesn't pay very much, but we have some companies that pay us $5, $3, $7, and when you're doing these visits, every little bit, and if you do 1,000 of them, well, $7 times 1,000 is not chump change. So in the treatment put out by the NHLBI, which I strongly recommend that you have these on hand, and also for the nurses, because I think that they will understand asthma management so much more if they can read about what the different steps mean. Some of the recommendations to refer out. So if you're thinking about starting an asthma program in your office, you may want to have some common denominator of who you're going to send out and why. So the recommendations by the NHLBI are, if the child's less than 5 and is at step 3 or higher, they should probably at least see a pulmonologist. Not that they're going to do anything different, but there are some esoteric things that we might not be thinking of. If 5 to 11 and step 4 or higher, those kids should get referred out for further evaluation, or in addition, some allergy testing, which is a topic for a whole other discussion, which you might want to consider in your practice as well. Again, greater than 12 and step 4 or higher, again, those kids might be your criteria to send out. So, in developing your asthma management program, considering what you're willing to see and what you're willing to not see, if you're just starting up, you may want to say, okay, I'm going to send out, anything above a step 2. Although I think if you really think about it and have a specific team that's working on asthma, these become relatively easily manageable. So the goal of all step treatment is to be at the lowest step with basically no symptoms, so symptom free. So basically, the cough goes away. They don't have cough twice a week. They don't mean the minimal persistent asthma criteria. So using your steps in addition with the proper diagnosis to make sure that you're at the best level for that child. And that means being on no albuterol. Right. So if we're renewing albuterol over the telephone, they're not using their medication properly at all. So in our practice, we don't refill any albuterol on the phone. They must come in for a visit. Either they're not, unless they lost it. I shouldn't say never, but if they lost it and they're up to date with their visits, we'll do it. But having refills for albuterol just means that they're clearly using it too much, or they're not taking their other medications that you prescribe for them. The other, and this is one of the quality metrics, this is kind of like ADD meds. So if you start a med, they expect you to do a follow-up in 2 to 4 weeks. So make sure you do your follow-up visits to make sure whatever step, whether you went up or down, is improving on the new management. Once stable, then asthma visits can be every 1 to 6 months, depending upon the time of year. So some kids who actually have issues in the fall may be coming in more frequently than your kids who are spring wheezers. And typically, most kids should be coming in every 3 months for evaluation and either, adjusting and always trying to go down clearly. In some kids, you may be only able to go down during certain times of the year, and during the other times of the year, they're back up again. But this is why a team in your office may be better suited to take care of these kids, because they really get to know them and their sort of individual nuances in their care. So one of the biggest foundations of asthma care is education. The more we can educate the parents, the child, the school with whatever forms we're going to give them, the better they can manage their asthma and the better job that we do. So, making sure that you have enough time in these visits to do the education that goes along with it. I think we'll talk about it in a minute, but we like to give our kids a binder. So we record in it when they come for their visits. We also give them hints on how to best meet their triggers, and address their triggers so that we can limit their exacerbations. Compliance and understanding, although we think of them as education, they're really separate, coming up with a compliance plan and recognizing, I always thought it would be interesting to have a compliance rating for patients, to show them that, okay, here is a grid and this is why your asthma is not doing so well. But hopefully maybe someday somebody will come up with that. The collaboration, so, this is my F slide, in case you didn't notice, and not in a bad way. So, the foundation of asthma care is education. Fostering compliance and understanding is tantamount. Facilitating collaboration. So this is a collaborative plan. It has to be, with the patient, the parent, the school, and you. Everyone has to be on the same page and be ready and willing to work together for the benefit of the child. Following the asthma action plans. So we can't say enough about asthma action plans. I think they've changed a lot how parents are able to manage their kids. Like if they do this, do that, they can understand colors, and making sure that those stay up to date, and that the schools also have an up-to-date copy. So when you make a change, be sure to give them one to bring to the school nurse. And form your team. Having a team that really manages asthma, almost like having a specialty program within your practice. It will be more efficient for the patients. It'll be more efficient for your provider. And it will be more efficient for those who have to receive information. So whether it's daycares, schools, after school programs. And then this last one, I'm not sure if all of you know that anyone can become an asthma educator. So it can be your MA, it could be a nurse. I suggest it's, clearly somebody on your asthma team. And this will allow the provider to see more patients, because when the provider is done doing the basic part of the visit, the asthma educator can go in and you can, bill by time, use your counseling codes. So, and it's not that hard to do. We have a couple in our practice. I don't think that your providers need to have it, but if you're starting up an asthma clinic in your practice, I don't think it's a bad idea. It's very organized. They give you a lot of tools to use, and it sort of helps formulate, if you will, a management program to follow within your practice. So, if you want to try to use asthma and creating this, let's just say, renewed asthma program in your practice, there are a lot of things you can do for a QI project. So, and we get recognized for some of these, whether it's through MOC or some of our insurance companies actually will do some, not only pay for performance, but you actually get an enhancement if you're working on some QI projects. So, if you follow severity, if you follow control, like how many people are using their controllers. A good one now, I think, that people could use is bringing back all your singular patients, because now we've been told to get all of our kids off of singular. So, doing a singular recall and bringing them back. And this is something with COVID that, you can easily do to generate some money. And if it's a singular, restart a new medication, there's no reason that couldn't be done potentially by a telehealth visit if they've been stable on the singular. The number of asthmatics versus the number of kids on an inhaled corticosteroid, which is the mainstream of asthma management these days instead of, the albuterols. Assessing triggers, what triggers are in your community and how do you address them? Follow-up. So documenting how you're following up these patients who are on chronic medication is very important to the insurance companies. Being sure doing a project, are all your asthma action plans up to date? Are all your care plans up to date? Recall strategies. What is your recall strategy? Do you have one? Do you follow it? It's a great way to have a steady stream of patients on your schedules, not last minute, oh, I need my asthma visit. It allows you to distribute these higher paying visits, throughout the year, or do them in times of the year that aren't very busy, like January or October, when things kind of slow down. Follow asthma paired with flu vaccination. Do you have a separate recall for kids with asthma and their flu shots, or a separate recall for chronic care kids and their flu shots? And, how do you measure what percentage of your asthma kids actually have their flu shots by X time of the year. We prioritize sometimes. We send out our flu invitation for visits to our asthmatic and chronic care kids first to line them up. Patient outreach. What can you do to improve population management and improve care? Insurance companies are going to be looking at you for ways to see that how you're managing some of these things, and asthma would be a great way to practice one. So the coding and documentation of asthma visits are typically detailed or comprehensive, and we know that's all going to change come January, so we'll have some other discussions about that. So typically level 4s and 5s, and often added time, because especially for the initial evaluation, it may take an hour or an hour and a half to go through everything. So being sure that you're getting paid for what you do is very important. So again, having an asthma team that also reviews not only what you're going to do for the children and how you're going to do it, but what happens after the visit. Like, are you getting paid? Are you documenting properly? Is key. Most asthma visits will also have enhancements, doing your asthma control test, using some of the tools that we talked about, and the education as well. And I can't say enough, I audit several practices and help institute some of these programs. And, it's really interesting to see how no one uses the 94664, which is, education and use of their gadget, whatever that is, which, pays $20, $25, and recommended by the NHLBI that almost at every visit you review with them how to use and how to clean their gadget, whether they're using a nebulizer, which as we know is almost extinct, going to spacers now. Kids don't use them properly. So making sure that not only, you're getting paid for it, but that one of your staff, and this can be done by a nurse, it doesn't have to be done by the doctor, it can be done by the educator, is going through with them and actually making sure that they're getting their medications properly. Understanding the detailed information to organize and document the visit. So I'm sure within PCC, there's templates you can grab for people that do asthma visits, or creating your own based on your own workflow. Like, how are you going to do the history inventory? How are you going to give them a form before they come in? Like, have you had any exacerbations? What your provider is going to need to make the visit most efficient. And if those can be reviewed ahead of time and documented, it just saves, more time face to face. Yet the medical decision-making doesn't really change. So having a lot of information up front is very efficient for these visits. Be mindful of the time, so time in and time out is very important on these asthma visits, because, if you've gone over 40 minutes, 99215, which is 40 minutes, and there's 30 minutes more added on to that, then you may want to, especially because most of it is probably going to be counseling and education, then you want to make sure that you're getting paid for that time. And then also in chart audits, making sure the medications are up to date. I can't tell you how much insurance companies are all over, did they get the medication? And you can see, like, even the pharmacies are getting, sort of haggard by the insurance companies, but I think some of it is self-serving for money. CVS will call you 100 times that your prescription is ready and you didn't pick it up. So making sure that actually the medicine you are prescribing is being taken and it's documented in the chart. Okay, so as you're developing your asthma management program or clinic, things you might want to consider are the different types of asthma visits you would be seeing, and making sure that the schedulers who are going to be booking these visits are very aware of what the difference is between these and the time you assign them. So for example, we book 60 minutes for a new asthma visit consultation. And pretty much that 60 minutes is totally used for that patient. Follow-up visits, depending upon if you change medicine or not, will be 20 to 30 minutes. My staff, they ask, if they're coughing or, they're coming in with something like, do you have asthma? Because we know we have to give those patients more time. So they're not going to get a 15-minute sick visit. They're going to get at least a 20 or 25-minute sick visit. So knowing the category of the visits and you assigning your providers or the way your staff workflow goes, the appropriate time for these visits. And especially for initial and like standard follow-up visits, I can't say enough about having an asthma clinic, like, 2 afternoons a month, and start with 1 or 2 full days, is so important, because as we talked about before, the missed school days and the missed, parent days at work, are significant. And a lot of times that is the barrier of getting these kids and families to come in. If they have a 4:00 asthma consultation and you're in the middle of, physicals and sick visits, and you don't go in till 5:00, like, they're not going to want to come back because they waited an hour for this special visit. Whereas if you do these visits scheduled as little mini clinics, you're on time. So if you have a 4:00, they're getting seen at 4:00, they're out the door at 4:30, and they can make it to the soccer field at 4:45. So, even if you don't want to do a formal asthma program, I encourage you to find blocks of time where you see these kids, or any of the other kids that you see that have a chronic disease, because they're missing out on so much stuff already from when they're sick, or, when they're exacerbated, or, if they wait too long to come in because their parents are busy, so making it easy for them is really going to win you their undivided attention. And really, they will feel much better that, okay, I have my asthma appointment, it's 4:00, and I'm gonna be out the door at 4:30. So I encourage you all to think about that a little bit. Exercise challenge test, usually we schedule at least 1 hour and 15 minutes, because you're doing the pulmonary function test like 3 times, 4 times, and if you have to give them a treatment. Now, with that said, you could double book an asthma follow-up in the exercise challenge visit if your MA or your nurse is going to be the one that's running the test. So sometimes another sort of pearl is to book your asthma visits, let's say at 8:40, and you're going to see the patient at 9 or 9:15, because the MA actually is at 8:40 doing the inventory, the intake, doing the PFT, so that the patient is ready for you. So trying to think out of the box and be more efficient how you schedule these, you could probably do 3 or 4 more visits if you schedule properly in the same clinic. Just to review some CPT codes that you can enhance some of these visits with, we already talked about the asthma control list. So the pediatric symptom checklist is really important, because a lot of these kids have emotional issues, and checking in with their psychosocial. So I encourage you to at least reference one that was done recently at their well visit, but if it's been like 6 months, they're not due to come in. So, maybe a pediatric symptom checklist in your asthma program is biannual. The asthma education for gadgets, we talked about already, and we made this as a order set in our where the orders are. So basically, the nurse orders it, it's documented, and you just fill in the box that 10 minutes or 5 minutes spent discussing asthma, use of spacer or nebulizer or whatever it is you're giving them. So it makes it easier to document these things. And also maybe making an asthma order set so that these things are all in one place, and makes it much easier for the providers to make sure they don't miss charging for something. Using the counseling codes, so where this might be helpful, let's just say you're doing an asthma visit, but they gained 10 pounds. So now you want to talk to them about nutritional counseling. So, you can add that on if you're not doing, a visit that's going to generate enough time. So remembering that these codes can be used in addition. When I left off is, we have teenagers now with asthma. So if they're smoking or using pot or vaping, you could use the tobacco. The 99406 would be another code you could add to some of these asthma visits. Also, if they're coming in an exacerbation, like the front desk says, oh, Johnny's coming in, he's wheezing, well, that's disrupting your schedule. Asthma visits are the perfect visits to use the interruption emergent visit to your schedule, the 99058. And these codes are not used much, but they actually pay kind of nice. So I encourage you to look at these, the nurse extended time. So if the nurse is spending an unordinary amount of time with the patient. Let's say you're doing 3 back-to-back nebs and they've been in there. These are great codes to use. The nurse has to document her. This has to be a nurse, not an MA. The nurse will document her time, and in addition to whatever you do, let's say the nurse spent, 30, 35 minutes. This is an added code again. So as I mentioned earlier, these asthma visits can be very enhanced. If you do these correctly. The additional time codes are listed there. There's 2 units after you get to 75 minutes of the 99355. And then the peak flow is an S8110. All right. So I know I went through that quickly, but I really wanted to get to this part. So really thinking about asthma and how you can like reinvent it in your practice and kind of make it its own is the team. And to really get this going and to manage it, you need a champion. And the champion has to be somebody who is committed to the goal and the mission. So the mission is you want to improve asthma management, not only for the quality of the kids, but the efficiency of your practice. And also the financial, making sure that you are getting paid for every single thing you do. So that person has to have a vested interest. It could be a nurse, it could be an MA, it could be one of the providers. It should be someone who has a little clinical knowledge. Some practice managers, have come from the medical background and will be a good person, but you want to choose someone who's going to get you across the goal. Join the team, who also has some interest in doing something different in the practice, and maybe you enhance them in some way financially if they want to take this on. And then choose someone or 2 people to become certified asthma educators. I can't say enough about how these can be used in a practice and limit, the repetitive information that one of the providers has to give, which is a higher, it's a higher cost to have a provider, do this part of the visits. And then assign a chronic care manager and recaller who could also be the forms person. So remember, asthma forms, asthma action plans, epinephrine, they all require, a fair amount of time. So having the same person who does it all the time becomes very efficient. They also know the patients. They know, okay, I have to fax this to this school, and they know where the fax number is, and it takes them probably, I'm going to say 1/10 of the time as a random other staffer who has no idea what's going on with asthma, doesn't even understand the medications, and potentially might even make mistakes in transcribing some of that information. Understanding that the scheduler who understands the complexity of these new clinic visits. So if you're gonna, book them, Wednesdays, from 2 to 5 twice a month, you want to make sure, 1, that it's booked, 2, that the visits that you're putting in there are booked correctly. So I suggest, and this is what we do in our practice, that it's the same scheduler who's doing all the asthma visits. Now, clearly you have to have a backup person if that person's out, but again, now you're expanding the team. So your team is now a champion. Your team has another person who might be helping the champion, who could be the CCM and the certified asthma educator, and then have somebody from the admin team, and then a provider or 2 who have an interest in asthma, who really want to take it on and really make a go of these, asthma clinics. And as I said, important to stay on time for these, not necessarily the sick when they're sick. Those can be seen by anybody, but for these where they're coming in for their routine management, you want to make sure you can get them in and out as quickly and efficiently as possible. The team above, being sure that you are checking your process improvements to see if there are any hiccups along the way. So, if you get one going, make sure in a month or 2, you kind of relook at it, get feedback from the patients. I would call it an asthma clinic or whatever you want to call it, breathing clinic or breathe right, or, come up with some, sort of catchy name. You can promote it on your website, and make sure you first, introduce your staff to these things. I think sometimes what happens is we'll add things and then the staff don't know about it, and then people are calling or talking about things and they have no idea what you're talking about. So even if they're not going to be involved in the team intimately, making a staff, meeting where you're going to present what your new asthma program is going to be and what it's for. Use your dashboard, follow that the indicators of, that the visits are happening, that their flus are up to date, that their wealth care is up to date. Again, asthmatics come in 3 or 4 times a year and they won't get their physical, they've been in. So, making sure they're keeping up on their other parts of their well care, or seeing the nutritionist in your office, if you have one, or talking to somebody in the office about healthy eating or some of the other comorbidities that you're dealing with. Again, think about having some recording for the patient, whether, I say a binder, it's paper. I know everybody's like anti-paper. I just don't know how else you could manage it. Or maybe you have an app for your practice that you give the patient that you develop. In fact, I just thought of that in my head, so maybe I'm going to think about one for my practice. But something that is with the patient so that they always have their information with them, I think would be very helpful to them and to you. Refills, as we discussed, won't be necessary because you're going to have a more formal program, and if they need a refill except for losing it, then something's not going right. They need to come in. Document improvements will position you well to win on pay for performance or be ready, at a moment's notice with a QI initiative. Marketing, we talked about just to the staff, how it's important. Patients will really appreciate these efforts, and you may end up attracting other patients because they feel that they are getting a little extra special TLC, which is exactly what you're doing here. The schools will realize from your practice that you're managing these kids better, so you might get some kudos from them. And do some data collecting first. Look at how many asthma patients you have, how many visits were coming in, and their revenue per visit, and see where you're at. And then, look at it again, maybe in 3 or 4 months after you have realized some of your improvements, both for quality, efficiency, and profitability. And I think that's it. If you want more information or you want to have a presentation for your practice, feel free to reach out to me. And I really appreciate your time today.
You appreciate us. My gosh, Dr. Marconi.
I know it's a lot. I'm sorry.
No, my gosh, that was fantastic.
Thank you.
There is nothing missed. I cannot think of a thing that you did not address. Soup to nuts. I mean, quality, clinical quality, documentation, billing, scheduling. You've got something for everybody in here. This is awesome.
Thank you.
Thank you. We haven't had any questions come in. Let me double check one last time. We hadn't had any questions come in through the chat, but if you don't mind a couple minutes, I've got a million of them.
Okay.
My own curiosity. I mean, I am walking out of here with ideas I did not walk in with, for sure. And just my curiosity about some of the observations that you made, like the statistics that you had shared related to patients that are affected. Is there even a keyword I could search on to discover if there are any theories about how the effect of puberty is so huge on this?
Well, you can, as I said, most of my information came from the NHLBI or the Asthma Network. You could just Google, asthma management in children and young adults, and, a lot of this will come up. Adolescence is sort of a weird time because, a lot of kids improve, but a lot of kids don't come in for treatment. As we know, the adolescents, we miss a lot of those visits. And, all the more reason that those are some of the things that you can discuss at their regular, how are they doing with exercise? Like, not what are they doing, but how are you doing with it? Like, prompt more questions. Like, do you ever feel winded? Because it comes up a lot, like they're winded, and a lot of times they just don't even know how to breathe. Like, okay, when you're working out, you're supposed to like not breathe in through your mouth, and then through your nose and out through, so like, some even just little pearls, really just by asking a question or two more of details, not like, do you exercise? Like,
Yeah.
how do you exercise? How do you feel after your exercise? So trying to get a little bit more information. But as we know, getting information out of adolescents sometimes is not the easiest.
Yeah. Well, and one of the themes in some of the questions in previous sessions this time around, one of the themes is patient compliance. So I really appreciated the point that you made that drug compliance isn't something that you're going to get out of a prescription module. You're not going to, you're going to see that they picked it up or that it was prescribed, but they're compliant. Do you have any suggestions or thoughts on the type of things that you want to record in compliance? Is it, or do you have any suggestions for any patients that may be non-compliant? Do you have any?
Well, I think if there was a place in the chart to notate, non-compliant, like NC, that going in, so you're going to be spending some more time with them. I think that having this team approach almost makes the parents and the patient more accountable, especially as the kids get older. So knowing that they're seeing the same person over a very determined schedule, like somebody's on them. And I think the chronic care manager, one of the roles for that person, and we don't do it, we can improve on it. I can, I'll admit it. Like, I think these kids should get called like in between their 3-month visits, like just a little tap on the shoulder. Hey, I'm calling to check in. How you're doing? Like, are you using your medicine properly? Also, some of the gadgets now have clicks on it. So make sure you tell the patients to bring their inhalers with them, and you can feel them, especially if they're getting near to empty and it's time for a refill. If it doesn't, float to the top of the sink when you put water in it, they're not being compliant, or the number of clicks on the thing isn't the right number. So, there are some metrics we can use to look at that. But I think making a point to the patient that you're expecting them to be compliant and you're going to check in on them goes a long way.
Yeah, then setting the expectation that ends up being a key part of it.
Yes.
And I absolutely love your idea about the patient binder. I've got some ideas already. We should work together and see if we can't get something into the patient portal like that.
Yeah, that would be awesome, because I know papers get lost and they forget to bring their binder, but they always have their phone.
Exactly. Yeah. For good or ill, right?
So that would be a cool project. I'd be happy to work on that.
I agree. Well, thank you again for this. This was really, I've got a million Google searches that I want to go do immediately.
Sorry.
Don't be. No, my gosh. My natural curiosity. This is the perfect assignment for me, is getting to sit and listen to you guys talk and watch you think. And until then, I hope everybody has a great day. And thank you again, Dr. Marconi. We'll see you soon.
Thank you too. Bye.
Bye.